and struggled with breastfeeding and all these other symptoms and experiences, I realized, gosh, we really don't know enough about this period, and we really have not paid attention to it. So this is a critical issue because moms are not prepared for common postpartum symptoms. This lack of preparation is actually consequential and is associated with multiple negative outcomes. And this lack of preparation is particularly problematic for low-income women of color who have more morbidity and mortality, more adverse pregnancy outcomes, who have fewer resources and less access to care. So when I finished my fellowship, I started with focus groups with moms and focus groups with obstetricians and midwives to better understand what women face postpartum and what were their adverse outcomes. I followed that up with a series of, a cohort study with a series of longitudinal surveys and did them at 3 weeks, 3 months, and 6 months to try to understand the prevalence of these conditions and the interactions women had with the healthcare system. I then translated that and moved on to do a couple NIH-funded trials to try to address some of the things I found, in particular postpartum depressive symptoms. And then I'm going to end by just sharing a little bit about what we're doing today with that same framework. So in our focus groups, as you've heard, the biggest things that came out were physical symptoms, vaginal bleeding, C-section, episiotomy site pain, incontinence. But people also, these women really talked a lot about depression, anxiety, isolation, and loneliness. And the themes that came out of the focus groups, both with clinicians and with moms, was that there was, in general, there was a lack of knowledge about postpartum health from the mom's perspective, that there was a significant lack of continuity and trust in provider, particularly for our patients who were insured by Medicaid or Medicaid managed care. And there was a large disconnect between providers and patients about what was important to communicate during that postpartum time. So we followed up with a survey, as I mentioned, and this was among 724 diverse women in New York City who had all delivered at Mount Sinai Hospital. And we asked them a series of questions about the symptoms that they experienced and whether their clinician, an obstetrician or a midwife at our hospital, had ever told them that they might experience these symptoms. And you can see here that there's a large kind of a disconnect, but overall kind of concerning that, for example, when you look at urinary incontinence, 32% of the women reported having any loss of urine, and that's in blue, as you can see. But when you ask them whether their physician or midwife had ever told them that they might experience that, it was only 24% who had ever been told that. And you can see, you can go through all of these. With breast pain, 82% of the women had breast pain, yet only 60% were ever told they might experience this symptom. 39% of our women screened positive for depressive symptoms, and the rates were much higher in our cohort among Black and Latino women than among white women. And you can see that the large mood swings were also a major issue. Again, 69%, yet 45% of their clinicians had ever talked about this issue. We sort of concluded after this that we really needed to shift the thinking in postpartum care and start thinking about preparing our women for this experience. And we ended a paper by talking about what the pediatricians did, right? This anticipatory guidance, this idea of preparing women, spending 15 minutes during your visit with them to talk about these issues. We actually did a lot of exploration around this with women in our focus groups about the timing. We did this also with the clinicians. You know, would this be good to go over during the 3rd trimester when you're coming in for all those prenatal visits, or would it be better, you know, when was the right time? And we can talk about that later. Well, our surveys, the final conclusions of our longitudinal surveys were, again, moms were not prepared, that the lack of preparation was actually associated with a positive depression screen, that they were less satisfied with their clinicians, and they were less likely to come back for their postpartum visit. Interestingly, in our study, which I didn't get a chance to really go into, but we really did focus on trying to understand what were the early stressors, the factors early in that postpartum experience that were associated with depressive symptoms in our cohort. And we found that it was this physical symptom burden that I've been talking about, infant colic, and lack of social support that were very important and strongly associated with depressive symptoms. And again, we found big differences by race, ethnicity in terms of breastfeeding and depressive symptoms. So we put this together, and I worked with a behavioral health psychologist, and we created an educational intervention, a behavioral educational intervention aimed at reducing postpartum depressive symptoms. And our trial was called Mothers Avoiding Depression Through Empowerment, made it. We targeted those same factors that I just spoke about. We prepared and educated mothers about common postpartum symptoms and experiences. Our intervention activated moms with practical approaches to common postpartum symptoms. Our intervention was 2 steps. A master's level trained social worker presented and worked with patients during their postpartum hospital stay, reviewed educational pamphlets, both a partner summary sheet and a patient educational pamphlet. Then the mom went home. The social worker called the mom 2 weeks later to reinforce those educational materials and then to connect the moms with resources in the community tailored to what they may need. It was implemented by a racially and ethnically concordant social worker, and we, for this trial, enrolled 540 self-identified Black and Latino postpartum mothers. Now this is a busy slide, and I'm not trying for you to, we don't have time to go through the whole thing, but I wanted to give you sort of the conceptual framework for what we're doing. We're doing patient education around those 7 elements of preparation. What to expect, time course, duration. We're targeting the things we thought were modifiable, these early stressors in the early postpartum period. We're also focusing on partners and giving some education around what to look out for in terms of depression and how important social support is. Here's a quick one little section of it about vaginal bleeding, and if you quickly go through this, you see it talks about why you have it, what's the duration, what can you do to sort of help yourself, what to expect over time, and what are the danger signs. So we followed women up to 6 months postpartum in this trial, and we found that our intervention reduced positive depression screens over time, and in fact it decreased it by 1/3 for up to 6 months, the odds of a positive depression screen by 1/3 as compared to controls. It also increased breastfeeding duration. We found that if you can see here, that in red is the intervention group, and the duration of breastfeeding was 12 weeks versus only 6.5 weeks for the median duration in the control group. So the next step is an RWJ study that we're currently running, where we're aiming to reduce disparities and improve quality of care for high-risk postpartum moms. We're targeting gestational diabetics, hypertensives, and late registrants. We're building off of the Made It intervention, and we're doing a case management intervention here, and our primary outcome is return for the postpartum visit. Here is a list of some of the questions that I think are still remaining, and we've touched upon some of these earlier in the afternoon and in the morning, but I think we still don't know what's important to moms and postpartum women, and we need to do a lot more work on that. And we really need to know how we connect women to care, because this is an opportunity to get them connected to the system, and we need to understand better how we engage women in care. I also feel like this issue of the right time of the postpartum visit, of course 6 weeks is much too late. I think it should be closer to 2 weeks, and I think we have to do a lot more work of talking to moms and clinicians about what's most important. So I'm going to end there. I'm 8 seconds over, and I just wanted to end with showing you some references. Thank you.